So, good morning, everybody, and welcome to Friday Chalk Talk. This morning, we're lucky to be joined by Dr. Ben Steyer. He is an outstanding transitional year resident who's rotating with us in palliative care this past month. And he's going to be starting his radiology residency at Penn State in just a few months. Ben is going to talk with us about a topic that has arisen this month, which is about futility and CPR. And I am intrigued to get his perspective as a newly minted physician and someone with a bit fresher eyes than most of us. So today's format's going to be 3 parts. Ben will provide us with a short presentation. I will follow with just a few minutes of my own, and then we will open it up for discussion for everybody. So with that, I hand it over to you, Ben.
Thanks, Dr. Mobazelak, for the introduction, and thanks for everybody here for letting me join and make this presentation today. So I wanted to discuss some kind of ethical and legal perspectives in CPR futility. I know this is a topic that is always kind of around and present. I think with the COVID pandemic, it came up a lot more. And so I think now is a time to revisit this. I understand you've had some discussions before, but I think it's a good time to revisit this and just kind of talk about what the current landscape is, and then hopefully we can share perspectives across this diverse audience or membership of this group. So I wanted to start today with outline. I'll provide some background questions for discussions, and then Dr. Mobazelak is going to chime in and provide some additional context as well. So first off, I wanted to start out kind of with transparency here. So disclosure is that the views that I'm expressing here intended to serve as a vehicle for discussion. They don't necessarily reflect my views in completeness or the views of my employer. And then I'm not an expert in ethics or law. I have no formal training in those. So this is my best attempt at summarizing the current state of these discussions in the US. And then perspective-wise, I think this is important when addressing these discussions, is I approach this from a perspective of a white, male, US-trained physician. And I think perspectives from other disciplines, backgrounds, cultures are invaluable when talking about these difficult subjects. So first wanted to define futility because as I, after chose the title of this presentation, did some more reading and realized that's sort of fallen out of favor. It's fraught with inconsistencies. It's kind of confusion of how to define it. Is it the absolute impossibility of a successful outcome, low likelihood of success, low likelihood of survival from discharge to hospital? There hasn't really been broad consensus or agreement on this, and it's become more, I'm not sure in vogue is the right term, but more common recently to use the terms non-beneficial or ineffectual when discussing things like CPR, withholding CPR. So first wanted to start sort of ethical considerations and bring the group up to speed. So from a medical perspective, as I'm sure many are aware, there are principles that sort of guide our practice. The primary ones that we discuss are beneficence, non-maleficence, respect for autonomy, and then confidentiality, distributive justice, or stewardship of resources are some of the major ones. And ethical dilemmas arise when there is conflict between two or more of these principles or values. So just to kind of discuss the US landscape for ethical considerations surrounding CPR futility, or in the US, as many of us know, patient autonomy often holds primacy, especially in these end-of-life considerations. And this is not the case in every country, and it was not the case really, especially the primacy so much in the US until the 70s and 80s, when there was a lot more of a patient-centered care movement in this country. Unlike other invasive treatments that required informed consent, CPR has become different. It's sort of a de facto standard that is performed unless patients representatives opt out. This is obviously, I think it's fair to consider CPR an invasive procedure, and it is interesting that that is one that we kind of hold different in terms of consent. In general, it's accepted that physicians are not obligated to render treatments that they deem of no or little benefit to patients. But in practice, well, most would agree that withholding treatments like chemotherapy is acceptable. Unilateral, so by providers, withholding of CPR against patient or representative wishes is fraught with controversy, especially in this country. So there are codes of ethics that professional societies put out. A major one is from the American Medical Association that guides a lot of what we do as physicians. Their most updated opinion on this, in terms of do not attempt to set resuscitation orders, says that authority to accept or request DNAR status resides with the patient or surrogate, not the treating physician, and instructs physicians to provide resuscitation when patients' wishes are not and cannot immediately be known. However, they do add that under certain conditions, it may be justifiable for patients to withhold CPR unilaterally. This is covered by medically ineffective interventions, which discusses physicians are required neither to offer nor provide care that cannot be reasonably expected to yield intended clinical benefit or achieve agreed on goals of care. So, you know, if you just read opinion 5.4, it seems like unilateral DNR is completely out of the cards. But if you consider CPR to sometimes be medically ineffective, it seems like there is some precedence for withholding CPR unilaterally, at least according to the American Medical Association. Now, the legal precedence for this is possibly even more murky in the US. One review I found published in 2019 does say that current case law makes it improbable that a physician will be held liable for homicide for withholding futile care. And it stressed that there's no universally established law, no federal law directly addressing the issue of withholding CPR on the basis of futile care. It seems like there's no universally established law. It seems like CPR has achieved a special status in which arguments of futile care do not apply. There are some laws in New York specifically that seem to be the most explicit in challenging physicians' ability to do unilateral CPR or unilateral do not attempt resuscitation orders. So one case I wanted to discuss that came up in my reading was Gilgan versus MGH in 1995, and this was illustrated by an article published in Chest in 2014. So this case had a 71-year-old woman with heart disease and breast cancer, hospitalized for diabetes and hip fracture, suffered seizures, lapsed into coma. Her daughter became a surrogate decision maker and made it clear that mother would always want everything done. Physicians decided that further care would be futile. This was taken up by the ethics committee, and it was decided that the option to offer CPR was not relevant because it was not a genuine therapeutic option. And they entered a do not resuscitate order unilaterally, despite strong protest from the daughter. The patient died shortly after receiving CPR. So this is based on a real case. So this article brought up several things, several questions kind of regarding that case. And they asked which of the following statements is incorrect. The defendant expert relied on the position of the American Thoracic Society that said that support can be limited without the consent of patients or surrogate. Fetal intervention may be defined as treatment that would be highly unlikely to result in meaningful survival of patient. Jury found that if competent, the patient would have wanted CPR. Jury found such treatment would be futile. And E, did the jury enter a verdict of negligence? And the statement that was incorrect here was E. And This case represents the best known litigated example of medical futility that's been addressed by the courts, and this was back in 1995. It supports the notion that futility of CPR can trump a patient's family's insistence on receiving such an intervention, but it's not that strong of a court verdict, is at least my understanding of reading through this literature. And the one thing I wanted to leave here as I get to the end is kind of response to this case law. An ethicist, M. Caprone, in response to this, and I'll just read this here because I found this compelling, said, "We still need means to reach a social consensus on whether health professionals should have the authority to decide among the interventions patients or surrogates will accept, which will actually be provided, and which they may withhold based on their evaluation of the worth of the outcome. When we come to adopt such policies, we would do well to ponder long and hard before adopting a utilitarian measure that affords the waning lives of the most vulnerable in our society less protection from unilateral decisions by powerful professionals." So I think there's a lot to digest and think about with that statement and the power of unilateral DNR. So I have some questions, examples for discussion that we can address. Again, these are just suggestions. I wanted to bring up to the group, are unilateral DNR orders morally acceptable? And if so, when? Is it only when a patient or surrogate wishes are unavailable that they're not able to comment on what the patient would want? Or was it whenever providers declare no medical benefit? And what are the practical pitfalls of implementing such policies? And then I just wanted to remind, as we bring things up for discussion, is to limit your discussion to hypothetical cases to respect patient privacy.
All right, thanks, Ben. Before we open this up for discussion, last night I was thinking about a few points I wanted to add. So I want to share three things. One is a study, one is a model, and one is a question. So first, the study. The study is from 2015, and it's from Dr. Elizabeth Zhang, and it was a qualitative, semi-structured interview of residents, fellows, and new staff about their experience with end-of-life and futile or potentially futile CPR. And the themes that came out of those interviews from these newly minted physicians were all about perceptions of torture of patients, demoralization from seeing their own attendings or their colleagues in situations of perceived powerlessness, dehumanization, and burnout. And I think the quote from these semi-structured interviews that moved me the most was from a third-year internal medicine resident that read as follows: "We are abusing a body, and I get that. But as long as I remember I'm only abusing a body and not a person, it's okay." Wow, right? What a statement. And I think all the quotes in this study are really highly emotional and compelling to see how much suffering a provider might face in these difficult situations, which does not take away from the family. I think it's just an interesting side. So that segues to my second point, which is about a model of thinking about autonomy and futility. And it comes from an ethics paper from the 90s from one of my favorite ethicists, Dr. Pellegrino out of Georgetown. And I'm going to attach it in a PDF in the email later today. And this paper makes an argument that the physician and the patient can each have their own autonomy and respect for the others in the process. And in this proposal, the patient and the physician are really two halves that make a whole. And on the one half, you have the physician who's the expert of the medical care and what options are and are not available. And on the other half, you have the patient who's the expert of their own values, an expert of their own goals and what they're willing to endure and not endure. And this paper argues that moral distress usually occurs when one sort of oversteps their boundaries into the other. And the physician should not try to be the expert in the patient's values, nor make assumptions about quality of life or goals, nor about what is perceived to be suffering. And the patient should not try to be the expert in the medical case. And so when both come together, you get to be the expert in your own domain. and really respect the other's expertise. And certainly that is easier said than done, right? And absolutely this requires trust in a relationship, which is often, I think, lacking in some of these cases where there is immense conflict that's bubbling up. And my third and final point is to add another question to Ben's, which is, I am curious what our social workers and our chaplains think about this case, or think about this situation in general. Do you guys perceive this differently than nurses and physicians do? Do you guys perceive this as suffering? I'm curious what you guys are thinking. So with that, we will just open up the floor to everybody.
You know, Marty, this is this is real good. Me and you have had conversations about this already, so you kind of know where I am, but I'll state it for everybody else. As a chaplain, when we're called to a code and we get there, normally we get there 5, sometimes 10 minutes after the resuscitation has started, right? So while we're standing there, and sometimes there's time to put us into the conversation by the head nurse or who's ever overseeing that part of the operation. But people are running around trying to get things to the doctors. When I'm standing back, it sometimes looks like futility. 10 minutes, 15 minutes, 30 minutes, right? And so I'm like, and nothing's happening. And so one time I had to ask, why? This patient, they're gone. And so it came to me, kind of asked the ethical question of the ethics department. And sometimes what's being done is to make sure that the patient stays alive long enough for the family to arrive. I just found that amazing. And so I don't know if I have an answer to this at all. I just wanted to bring that point up because is that good enough reason to make the person suffer? I understand the body part, but I don't understand making the person suffer that long, especially when they're already gone. So hopefully somebody can help with that.
Thank you, Liddell. I appreciate that.
To answer specifically to Liddell's question, as being a provider in the ICU and being the person who's done the CPR, run a code as a nurse practitioner in the ICU, oftentimes if they're getting close to that point where they need that and conversations have not been clear, there's that we have to, and a lot of times it's, we're going to do this until they show up. A lot of families will say, keep going until I come, because we want to be able to say goodbye. In some people's minds, they think that if somebody else is keeping their heart going for that, whatever that time is, that when they get there and they can say stop, their loved one is still there. And so then maybe that allows that saying goodbye piece. And from the provider and the staff side of things, from our perspective, a lot of times we see how much it helps family to see what's going on and to see the code situation, and know how, everything has been tried, everything has been done, and this is where we are. So it allows them to process that, yeah, actually everything was done, but they still passed away. It's sort of it enables that grieving process. And while so many of us in critical care have felt, why are we doing this? This doesn't make any sense. In my role now in palliative care, I see why we do these things, because this is what they wanted. and the family feel that they've tried everything. So it's hard for staff to stomach it most days. And I've come to terms with saying, but this is what they want, you know. And then this is again in the case of when patients actually are choosing it, right? So not in the ones who we don't know their wishes, but in the ones who choose full code. So I think the going through the motions and doing it, even though we know the futility of it, does have its benefits for both the family and for mostly just for the survivors, not necessarily for the staff.
Thanks, Maureen. Yeah. One thing that is, oh, Jennifer, I saw that you
Hi.
you unmute.
Yeah. I just wanted to dovetail Maureen's point, which is really well taken. I find in my practice that it all goes back, a lot of times it goes back to informed consent and making sure that that patient is truly informed of the potential outcomes of CPR. I find oftentimes that is not the case. We all know that it's all in the message and how well things are explained and how they're explained. And I find that sometimes it's not until the patient has a palliative care consult that they truly are informed and understand the implications of CPR. And dating myself, I will say that many years ago, there was a study done that patients were actually shown the process of CPR and the potential outcomes of that. And oftentimes would choose not to have CPR in their particular situation. So it's like it can be therapeutic, so to speak, for a family to see CPR and be able to know that everything is done. Conversely, I think if a patient understands the implications of CPR, they may choose not to have it. And just to kind of add to that, patients oftentimes have never heard of or understand the concept of allowing natural death. And sometimes it's until there's a palliative care consult that they are made aware of that and can embrace it and make a good choice for DNR. Some patients can't go there. They're going to go out fighting regardless, and they certainly have the right to do that. But I think it's all, not all, but a lot of it goes back to how well informed that patient is, how they're able to integrate the concept of CPR and the potential outcomes in the context of their own situation and their own person, that can be truly cathartic in them making the right decision for or against CPR. So I think, hopefully in a better world, a patient will be able to be given that opportunity before they have a palliative care consult. But I think it really goes back to the providers and the patient's ability to integrate what's told to them that can be very crucial in this, in this decision.
Yeah, wonderful.
I wanted to, if I may jump in to echo what Jennifer was discussing. What she brought up is if patients are better informed of or shown CPR, it often changes their decision to enter a DNR, to become or to say do not attempt resuscitation. That came up a lot in many studies. I think education seems to certainly make that more clear. There was one point that was brought up that I just felt like I wanted to mention that I thought was really interesting is, for most other invasive procedures, we go through, this is where you're at, these are the options that you have. But for CPR, we often say it as, this is a yes or no question. We don't say, do you want, if your heart stops, do you want CPR? Do you want to be intubated, yes or no? Maybe not so much in the palliative care realm. I agree these discussions are longer place, but especially from the general medicine perspective, we just address it as a yes or no question, obviously. or honestly, most of the time, that's how it's trained, and it doesn't really get the same discussion of these are the risk benefits alternatives that most invasive procedures get in medicine. I just found that interesting. I think something that maybe we can all do better of as providers.
If I can argue
I'd like to
the,
respond to that. I think that that is very, very true. And in addition to that, or implied in what you just said, really CPR needs to be explained within the context of the patient's condition and their goals of care. It is often, presented as a yes or no question. If you die, do you want us to save you? Those kinds of, well, yeah. So, when it's presented in such a black and white manner, I think that patients will often defer to CPR just for fear of not knowing what the other side might bring. So that yes or no component, I think, can be very misleading for patients and also for providers. I think providers are in some ways just as vulnerable as patients are in terms of having these discussions and having thorough discussions. So, explaining CPR, not just the components of CPR, but CPR within the context of the patient's condition and what their expectations are for recovery, I think would just be a huge leg up, not just for the patient, but also the provider.
thank you. Ben, when I was listening to you talk, I was thinking of our presentation from 2 weeks ago with Ann Broderick, when she talked a little bit about the warrior mentality of some VA patients going out fighting. And I think if you think about that scenario in this model of the two equal experts, one an expert of values, one an expert of the medical experience, you could imagine a scenario where you could change the details and have one trump the other and vice versa. And so I do get a little bit leery about always giving physicians the trump card, because I think that there are scenarios where values may, in really extreme situations, potentially override that. Something to think about. So we're just about at our time. We really appreciate you coming by, Ben, and giving your presentation. It was wonderful to have you.
Thanks, Ben.
Yeah, thanks for having me.
Absolutely. All right, everybody. Have a
Thank you,
wonderful
sir.
weekend.
Yep.